So after the ECG screening, then we'll go to another important screening for athletes, echocardiogram. And the next talk will be, the next lecture will be given by another experienced professor, Dr. David Oxborough. So Dr. David Oxborough is a registered clinical cardiac physiologist specializing in echocardiogram for the past 19 years. And he has worked in the National Health Service, private healthcare sectors, and various cardiovascular screening environment. Dr. David Oxborough has contributed to external committees and is currently the past chair for CASE in the UK and the chair for the Research and Audit Subcommittee of the British Society of Echocardiography. He also has written national guidelines for the role of ultrasound in pre-participation screening of the athlete and the echocardiographic assessment of the right heart, as well as contributing to numerous others. David is also a reader in cardiovascular physiology at Liverpool John Moores University, where he actively researches the acute and chronic effects of exercise on cardiac structure and function. On this subject, he has been invited to lecture at various international and national conferences and has published over 70 peer-reviewed articles. So with his vast experience in physiology, we'll hear how the important role of echocardiogram and how to differentiate physiology from pathology. Thank you, Dr.
Thank you very much. Thank you. Did I write that introduction? Almost as long as Professor Samaru's. Okay, thank you. I'd like to thank Professor Gary Mack and the organising committee for this kind invitation. It's a great pleasure to be here in Hong Kong and to be able to talk about a subject which I'm really very, very interested in, which is the echocardiographic assessment of the athlete. So I'm going to work my way through this talk in a kind of a practical way. So I'm touching on many of the things that John and Keith and the other speakers have already touched on, but I'm going to take it further. I'm going to talk about the role of echocardiography and where it fits into the diagnosis and the differential diagnosis of the athlete. So if we look at the pathway, well, the athlete arrives, as we see, and then they go through a written informed consent, they have height and weight taken, they complete their health questionnaire, they maybe have their blood pressure, they definitely have a resting 12-lead ECG, and in some cases, they will have a resting echocardiogram. This will then be interpreted by a sports cardiologist who will refer them on or clear them to complete Keith. Now, as John was mentioning, it doesn't always fit this way, and sometimes the resting 12-lead ECG can be assessed and can be diagnostic on its own. And if we get changes that are non-training, then the athlete is referred for an echocardiogram. But the bottom line is that the aim of the test is to differentiate between physiology and pathology. And that's what the role of the ultrasound examination is there for. So going back to Keith's lecture at the very beginning and thinking really about normal athletic adaptation, there's two distinct types of hypertrophy. There's concentric hypertrophy, this is of the left ventricle, and there's also eccentric hypertrophy. Concentric hypertrophy is mainly a manifestation of an increased afterload, and this is an increase in wall thickness, but no real change in cavity size. Eccentric hypertrophy is an increase in cavity size, but an also concomitant increase in wall thickness to counterbalance the wall stress. Now, as Keith quite rightly said, the Morgenroth hypothesis initially suggested that this was very apparent in athletes, but is more likely to be eccentric in endurance athletes and in concentric and resistant athletes. But there's now data to refute this. And I'm going to show you some of the ways that we look at the geometry of the LV from an echocardiographic perspective, and how we can really define that. So this is concentric hypertrophy, increased wall thicknesses, eccentric hypertrophy, increased cavity size. Now I've put this diagram in the middle here as well, because this says, okay, cardiac adaptation is dependent on training status, training volume, training discipline. But there's also a number of other demographics that influence this. And so before we start that echocardiogram, we've got to think about all the other demographics that may influence cardiac adaptation. So I'm now going to talk a little bit about how we define concentric and eccentric hypertrophy. Now, the standard in the past has always been to look at wall thicknesses and to look at cavity size. And these are linear dimensions. The final slide from Keith George's presentation was based on the fact that some of this could be related to body size. And so this is from the American Society guidelines on how they define geometry. And they look at left ventricular mass, and they look at relative wall thickness. Now, the relative wall thickness is a 2 times the posterior wall thickness divided by the internal cavity. So you get a relative ratio of the wall thickness to cavity size. And we can define geometry as normal, concentric, or eccentric based on an increased LV mass and an increased wall thickness, relative wall thickness. And so this is something now that we're pursuing through our cardiac screening, through our echocardiograms, to really say, okay, has this athlete truly got concentric hypertrophy, even if his wall thickness is 13 millimeters? And in fact, this was work that our PhD student, Victor Hitomi, did, published in Heart a couple of years ago, looking at around about 36 athletes. And if you look and you define it in the way that I just suggested from the American Society of Echo, many of these athletes have normal geometry. A few have eccentric hypertrophy, and one here has concentric hypertrophy. This is data that's unpublished from, again, another PhD student of ours looking at ice hockey population, elite ice hockey players, very dynamic in their activity, and predominantly, in fact, every one of them has normal geometry when you index them for body surface area. Now, I've just recently been to do Team Sky with the cyclists and Pro One, and I can say from anecdotally at this stage that most of those guys fit into this eccentric hypertrophy here. What is key from this is that very few, if no, athletes sit in concentric areas here. And that's really just reiterating what Keith was saying earlier. So in conjunction to the fact that you get this physiological adaptation from all these numbers of demographics, there's also the issue of pathology. What are we doing? We're trying to differentiate physiology from pathology. So the key pathologies affecting the left side are hypertrophic cardiomyopathy and dilated cardiomyopathy. Now, it's pretty easy sometimes, and this is from an echocardiographic perspective. If we get something like this, this is a hypertrophic cardiomyopathy. You've got a big septum, you've got systolic anterior motion, you've got an increased echogenicity, big left atrium. This is a Barn-Doe hypertrophic cardiomyopathy. If an athlete comes through a clinic and we do this, there's no issue. Well, there's an issue for the athlete, but there's no issue in the diagnosis. Likewise, this is one of a dilated cardiomyopathy, big left ventricle, much bigger than some of the athletes we see, but the fact is that the ejection fraction is around about 20%, so very, very poor function. And this is an arrhythmogenic right ventricular cardiomyopathy, and you see the big right ventricle, much bigger than what we would define in physiology. We've got aneurysms and dyskinesis up here. So these are Barn-Does, and this makes our life easy as an echocardiographer. However, this isn't the real world. And what we do see with athletes, particularly when they get to an elite level, is that they don't have this Barn-Doe. They never would be able to reach that physiological demands if they had such marked pathology. So often, the phenotype of the disease is much lower. And the athletic adaptation is sometimes much more extreme. So that grey zone that Keith and John have talked about gets bigger. And it makes our challenge as an echocardiographer much more difficult. So I'm going to start by just working through some case studies. That's kind of set the scene. This is what we have. The point about thinking about LV geometry, defining it slightly differently, is really important. And based on that, we've put together a screening guidelines. And this is from the British Society of Echocardiography. It's up for review, and I'm presenting the algorithms today for the first time. And this was published in 2013, so these algorithms are going to be in the next 6 months or so. This is worth thinking about. If you're going to be doing echo in an athlete, look at this algorithm. Because now, at the top here, first thing I want to do is say, okay, has the athlete got concentric or eccentric hypertrophy based on LV geometry and relative wall thickness and LV mass? And up here, if it's a male athlete, if it's over 115 grams per meter squared with a relative wall thickness greater than 0.42, we define that as concentric hypertrophy. If their LV mass is elevated over 115, but they have a lower relative wall thickness, that's eccentric hypertrophy. So that's the first step. Let's define LV geometry. Once we've done that, then we can think about function. If they do have hypertrophy, we think about diastolic function. We think about some of the parameters for assessing that, including transmitral Doppler, tissue Doppler. And then we think about systolic function, and we think about ejection fraction and S prime, which is TDI. We've added something different in here, and this is new to these reviewed guidelines. And this is the concept of an exercise stimulus. And I'll present a case in due course which highlights the importance of that. If these athletes present with hypertrophy, and then they have abnormal function, you have to consider pathology. But this is a key box here. You've got to correlate it with clinical data, with ECG data. It doesn't stand on its own right. You've got to think about other investigations and think about family history. So the measurements we take, well, these are linear dimensions. And this is from a peristernal long axis view. We do the septum. We do the posterior wall, and we do the internal cavity. And this is at end diastole. Something new that we do, or not new, but something different to a standard echo, is that we do these measurements of the wall thickness all the way around at different levels, at base, mid, and apex. And this way, we can get a comprehensive view of wall thickness. Because in certain conditions, wall thickness is not globally or uniformly distributed. So here we go. This is case one, right? We've got a 27-year-old male professional elite cyclist, Caucasian ethnicity. He's referred for pre-participation screening. The athlete engaged in dynamics. This is endurance exercise. Based on this, we're going to expect them to have maybe eccentric hypertrophy. This is approximately for 30 hours a week. So these guys are pretty well conditioned. There's no symptoms and no family history. His clinical examination, blood pressure, height and weight are unremarkable. I'm going to try, I know it's a big audience, but I'm going to try and make this relatively interactive. But hands up who think this ECG here is normal. This is an elite athlete. Anyone who interprets ECGs? Okay, anyone think it's abnormal? Okay, anyone unsure? Okay. This is a normal ECG for an elite athlete, and you can see he's got a marked bradycardia. Okay, there's a little bit of artifact, he was a bit tense. There's first degree AV block, there's possibly an incomplete right bundle, slightly pushed up or early repolarization here, but this is quite normal. Okay, so this guy comes in, he's got a normal ECG. This is his echo. So this is a parasternal long-axis view. Function looks good. This is apical four-chamber. Again, equally, function looks good. Chambers look relatively big. He's got a cavity size of 56 millimeters. Now, for a chap, for a gentleman, this is upper limits of normal, if you were just to take that by itself. Wall thicknesses, 11, 9, 10, 10, 9, 9, 10, 11, all the way around here. Very, very normal, but upper limits of normal. Now, if I go back to this concept here, he was an elite cyclist, and he was quite small, not much bigger than Professor Somerville. And when we started to index him for LV mass, it turned out that he had an LV mass index of 136 grams per meter squared. So this is higher than the 115. His relative wall thickness was normal. It was less than 0.36 with a maximum 11 millimeters. Bottom line is, he had eccentric hypertrophy. You would have said that was completely normal, 56 millimeters, but once we start thinking about his body size, he has got eccentric hypertrophy. We went on to do a functional assessment, and if we look at this, I'll come back to that slide. If we look at this here, he's got eccentric hypertrophy, so we go down, we look at diastolic function, we look at tissue Doppler, we look at ejection fraction, we look at, again, systolic tissue Doppler. Ejection fraction was 66, and these velocities of S prime of 10, 13 for E. These are normal at the lateral wall and the transmitral. All very normal functional response. So eccentric hypertrophy, normal systolic and diastolic function. These findings are consistent with an elite athlete. Okay? The point from this is that he has eccentric hypertrophy, even though from the standard linear dimensions, you wouldn't have said so. Okay, case 2. We've got a 22-year-old male professional boxer of West African ethnicity. Boxing is an interesting one when you look at the Mitchell's classification, which was presented on the first presentation today. It fits right at the very top. High dynamic, high static. These guys are doing a lot of exercise, and a lot of exercise of variable type. 25 hours a week, so working relatively hard. No symptoms, but he has a family history of unexplained death. Examination, normal. Height and weight, he was relatively small again, and quite lightweight. ECG, conscious of time, but hands up, normal. Hands up if you think this is a normal ECG. Okay. Abnormal. Okay. One thing that jumped out at us when we did this was very subtle T-wave inversion here, and some flattening of the ST segment that you could say is going down to about 1 millimeter here. John's presentation previously suggested that T-wave inversion laterally is abnormal. In some people, it can be normal through the leads, particularly in black athletes, but laterally, it's not usually normal. So this is starting to raise some alarm bells to me as an echocardiographer. So I go ahead and do the scan, and this is the chamber, this is the parasternal, this is an apical view, but focused on the left ventricle. Wall thicknesses. The basal septum, I don't know if you can see this here, this is 13 millimeters. In a black athlete, they say it should go as high as 14 millimeters. But it's not the same all the way around. In fact, 12 down here, 10 here, mid-level quite normal. His cavity is 61 millimeters. Now, this wouldn't be a hypertrophic cardiomyopathy because surely that's always a small cavity. It's a small cavity and increased thickness. But then we go and look at this geometry and we say, okay, well, we go through LV size. His indexed LV mass is massive. 188 grams per meter squared. He's quite a small chap. But his relative wall thickness now is above 0.42. So this now goes into what we call concentric hypertrophy. According to Keith, according to me, we don't really like that. We don't think that's normal. But it's not blatant HCM. There's no asymmetric hypertrophy or any outflow obstruction. So looking at this here, it fits into the concentric hypertrophy based on that 13 millimeters. So we do a functional assessment. His ejection fraction, systolic function is normal. But look at this. His global filling on his E wave is lower than his A wave, so his EA ratio is reduced. This is not normal in athletes who normally have very good suction, and it pulls that blood through in early diastole. And more so, his tissue Doppler velocities were very low as well. So we go down the algorithm. He's got concentric hypertrophy. His EA ratio is less than 1. His average E prime, well, I just showed his septum, was certainly less than 9. This was normal, but we had to consider pathology. We had to. He's also got an abnormal ECG. He's also got some family history. He went on to have MRI, and there was patchy fibrosis, and he had a mild phenotype HCM. Now this is the stuff we get, and this is the stuff that's really difficult. The reason why he has such a big cavity at 61 is because of his training. So even if they have HCM or a phenotype for cardiomyopathy, they can still get cavity dilatation due to their exercise stimulus. What was key to me was this here, this concentric hypertrophy, and this functional assessment. Okay, I'm going to present the last left ventricular case, and this one is looking at the concept of this exercise stimulus that I brought into the new guidelines. And why did we do it? Well, this is why. We have a 25-year-old male elite footballer, West African ethnicity. Football fits into the bottom right, so high dynamic, low static, but we'd expect eccentric hypertrophy. 15 hours a week. Even though he's a lead, they don't work as hard as most of the other athletes. Examination, blood pressure, completely normal. ECG, okay. Normal or abnormal? Hands for normal. No, everyone's a little... Hands for abnormal. Okay. We think this is normal, okay? We think this is normal. We don't see anything wrong with this. Echo. He's got a heart rate that's nice and steady, around about 59 beats per minute, 47 on some occasions. But when I first saw this, I'm looking at the function, the systolic function here. I'm thinking it's not contracting very well. It's really quite sluggish. And the same with the chamber here in the left ventricle. If we're looking, we shouldn't really do this, but if we just look at fractional shortening, it's down at 26%, which is on the borderline of normal, or low normal, but we did an ejection fraction, and we did it Simpson's biplane, and it's coming out at 47%. The normal range now is 52%, and yet in this weird area where you're thinking, okay, is this normal, is this abnormal, is this a dilated cardiomyopathy? Tissue Doppler, S prime, is around about 5 centimeters per second. This is really, really low. And his E wave and A wave are low as well. Lateral wall was actually okay. S prime wasn't so good. So systole, and we weren't sure about. One thing also that was very interesting was that the time period from the end of diastole to the start here was prolonged. So it was taking longer to actually get the ventricle to start. This is the isovolumic contraction time. So what we did, and this isn't the athlete for anonymity reasons, and we put them on a couch and we exercise them. We get them working hard. This couch slopes to the side, so it allows us to get the echo pictures. And you can see we can still get images even though he's... Oh, no, you can't. You can believe me, they were the best pictures. This is what happened when he'd... it literally got his heart rate up by 20 beats per minute. We're going up to 79. We're already seeing an increase in function. Look at this S prime go up here. This was before, this is after. E wave, big increases in annular velocities. But equally, that isovolumic contraction time just significantly reduced, which meant it had that kick, it had that reserve, and it's this reserve that is really important in athletes. So we could, without the exercise stimulus, have said this is a query DCM and sent them for further investigations. But based on this and the fact that we had an increase, let me just restart this, guys. I was telling John that this doesn't happen to PowerPoint. Based on this increase here with 22 and 55, we're working at the moment on finding out what the magnitude of normality is in patients with DCM and if there is any increase. But this was important because they increase their heart rate and they increase their ejection fraction and they increase their tissue Doppler. This was considered normal. So this isn't as simple as just a simple echocardiogram. This has become an exercise echocardiogram. Okay, before I move on to the right side, and the right side is certainly much more concise than the left, I'm just going to put some key points here. Expect enlarged left-sided chambers. Wall thicknesses very rarely exceed 12 to 13 millimeters, but that aside, provide a description of L geometry that is based on body surface area. Functional assessment is key. Diastolic function precedes systolic dysfunction in many disease states, and consider an exercise stimulus if you're in doubt. But always interpret in context and use corroborative techniques, and I think that's been the underlying theme of what we've been talking about today. So I'm really impressed with these slides here. This is going very well. So let's go to the right ventricle, and hopefully we can get through 2 slides without it stopping. Okay, the measurements we're going to make, this is what we would do for a standard conventional. And we did the workshop yesterday. And if you think about doing an echo in a clinical practice, you don't always interrogate the right side as thoroughly as you should do. In the athlete, it's really important because arrhythmogenic right ventricular cardiomyopathy accounts for anywhere in the literature between 3 and 16% of sudden cardiac death in athletes. So we take measurements according to the tradition, the American Society of Echo. We do this RVOT plaques. We do an orthogonal cut to RVOT1 and RVOT2. And then we also look at D1, D2, and D3. And then we look at the ratio to the left side. So we get a real comprehensive assessment of that right heart. And the reason we do that is because of the Marcus criteria. And Marcus criteria, the task force for ARVC in 2010, said we've got major criteria. If you get any one of the following, which is RV outflow tract increases of this size and poor function, but with a abnormal wall motion, then that's major criteria for ARVC. What is important to note here, though, is that this concept of having dyskinesis, akinesis, or aneurysms is a part of the criteria. So an enlargement by itself is not the major criteria for this condition. You've got to have dysfunction. So we put together an algorithm for this as well. I'm going to run it through here, This is probably going to be simpler. And we started going, okay, well, we can still get eccentric hypertrophy. If you've got concentric hypertrophy, this is wall thickness of the right ventricle that's increased. That's abnormal, full stop. That very rarely happens. Consider pathology. But dilatation does happen. And we go back to a functional assessment. We do TAPSE, fractional area change, maybe some tissue Doppler, consider exercise maybe. But this is a new bit here. Is there evidence of dyskinesis, which is out of sync movement, akinesis, abnormal or lack of movement, and or aneurysm? So I'm going to present 2 more cases, and then I'm going to wrap it up, okay? Case 5, we've got a 36-year-old, can't be 36-year-old, it was an elite professional cyclist. Yes, he was 36, but he wasn't academy. He was an elite professional cyclist. Engages in high static, high dynamic exercise. On examination, his blood pressure was unremarkable. This is his ECG. Normal, abnormal. Normal, show of hands. Yeah. Yeah. Okay, so this is abnormal. Again, very marked bradycardia, but nothing else. A little bit of early repolarization, but no T-wave inversion, no abnormalities. So hopefully the echo will work if I move down here. These are all stills. We did the measurements. We're measuring 29 here, 33 here, 31 here. I think that's measuring 54. 54 at D1 here. These measurements here are all above what we consider normal. And in fact, more so, this measurement here fits the minor criteria for ARVC. Doppler, tissue Doppler was normal. TAPSE was normal as well. So functionally, it was normal. And if we go and look at the algorithm, they met this criteria here with a 33 millimeters there. RVD1 was much bigger, big right ventricle, but function was normal. And if we look at the images, there were no dyskinesis or abnormal wall motion abnormalities. So this was considered normal for an elite athlete. This one, however, slightly different. 21-year-old recreational long-distance runner, Caucasian ethnicity, engages in predominantly dynamic training 12 hours per week. On examination, normal. ECG, normal or abnormal? Because I thought I might give you a clue with this last one and highlight some things. Normal? Abnormal? Okay. So remember what John said about ARVC and about a T-wave inversion. It's in 2 adjacent leads, but it extends all the way through to here, and there's something going on here. But there's also a massive ventricular ectopic here as well, which is of right ventricular origin. So we're already raising some query about what's going on, and this could be consistent with ARVC. And I'm hoping these images move. Good. So these were the measurements. 40 millimeters here. 40 millimeters slightly offset because the valve was rotated round. This is 40 millimeters. And remember the cutoff 32. So this is still big, but could still be consistent with athletic adaptation. The right ventricle does get big. You know what? In all my years, I have never had slides do this to me. But this is important. This is his function. Perfect. Okay. We've got this area at the apex here that is dyskinetic. So he's got a big outflow tract, and now he's got wall motion abnormalities. And the same here at the apex here on the subcostal view. So we have to consider pathology, and that fits in very well with his ECG as well. Ultimately, he had dilated 40 millimeters, normal function from these, but very dyskinetic. So don't always rely on these measurements here, because almost a subjective assessment can be helpful. He went on to have CMRI, and he did have a mild phenotype of ARVC, or well, a phenotype of ARVC. So key points to the right side, I think I've gone over by a few minutes, I do apologize, but we're almost there. Expect enlarged right-sided chambers, more likely to get RV inflow dilatation. Athletes often have a single criteria for ARVC, but look for that wall motion abnormality. Functional assessment is key, and identify regions of dyskinesis. So echo really does play a part. We're trying to move it away sometimes from the pre-participation screening, but it's really quite an important measurement and assessment. Just move this out of the way. 16 to 19% of sudden cardiac death in athletes can be related to anomalous coronary arteries, and I don't think it's really been touched on in this talk and the previous talks. Echocardiography is absolutely fundamental at identifying the ostia of the left and coronary arteries, the right coronary arteries. You often see these. In fact, I'd say in over 90% of athletes, you will see the ostia, and you've got to make sure they're there. This is a right ostia, this is a left ostia. The point is that if you can't see it, it doesn't mean there's any abnormality, but what it does mean is you should go and get further imaging. You should get MR, you should get CT. It raises a question. I'm going to leave it there. I apologize for these appalling slides, and if you get a chance, read the guidelines from the BSE. They're available online. They're going to be reviewed, so well, thank you.